Welcome to Nexus Medical Media. This is the second part of surgical site infections. So if you didn't watch first part, please click the link on the top right corner and watch that video first, because this is a continuation. Right, let's talk about the risk factors for surgical site infections. Right, so the first one is obviously infections. I talked about the degree of infection prior to an operation. Right, so that's our number one. There is a smoking, aging, because increasing age, it means you are at risk, because poor healing, because as you age, the skin also ages and other tissues, right? Next is malnutrition. If you are malnourished, there is poor healing and therefore a risk of a surgical site infection. Immobilization, that's why we want to make sure the patient get out of the bed as soon as humanly possible. Someone who is diabetic has a risk of getting a surgical site infection. Someone with a vascular disease, like if we talk about peripheral artery disease, if there is poor distribution of blood, right, towards the surgical site, it means there will be a hypoxia in that area, and there will be a risk of a surgical site infection. And last but not least, there is immunosuppressive therapy. Here we talk about glucocorticoids. Someone who has a malignancy and is on chemotherapy, radiation. So these are the risk factors. So when you talk about prevention of surgical site infections, basically we are trying to address these risk factors, right? So in prevention, we can classify our intervention based on pre-operative, intraoperative, and post-operative. In pre-operative, we want a well-optimized patient. How do we do that? If someone is diabetic, we make sure there is a proper glycemic control. If someone is malignant, we make sure we intervene. If someone is malnourished, we make sure we address that before the surgery. If someone is smoking, we make sure we would actually encourage the person to quit smoking for 6 to 8 weeks. However, we can also use those nicotine patches. I saw another literature which was saying for 4 weeks, but 6 to 8 weeks is a good range. This is addressing the patient, like optimizing the patient. We also need to look at the surgeon, someone who will be operating, right? Is still pre-operative. We need to think of hand washing, and we need to wash the patient with running water and to put a clean linen. Intraoperatively, for the surgeon, it's just the same: hand washing, proper scrubbing, and using sterile pack. On the technique, firstly, we need a minimally invasive procedure like laparoscopy, right? So a question may come saying what are the advantages of a minimally invasive procedure, right? So one of those advantages is a low risk of surgical site infection, but there are a whole lot of other advantages that we actually need to be prepared to answer, right? And also, you have to minimize a blood transfusion. On the environment, maintain an optimal temperature and make sure there is oxygen therapy. And the most important is antibiotic prophylaxis. I will talk about this in the next slide. Then in post-operative environment, again, optimal temperatures and oxygen therapy. There is a need for hand washing, and you teach the patient to clean properly, to clean the wound. And while the patient is still in the wards, you have to make sure the patient is properly cleaned, the wards are cleaned, and there is early mobilization, right? And in this case, you need to look into something called ERAS protocol. ERAS protocol. This is very important. You need to look into this. And then you have to enhance nutritional status, especially glycemic control. And still on that note, early feeding, right? Early feeding reduces the physiological response to surgical stress, right? So the question will come like, when do you think you can feed this patient? Some use evidence of bowel movement, for example, passing gas. All right. But I think the best answer is you need to feed the patient as early as possible. Some will use appetite, but now it all depends with who you are asking. But as early as possible, that will be the best answer, right? So, and still there on post-operative, we have the antibiotics, right? So let's talk about antibiotics a little bit more. Right. So for antibiotic use, firstly, we have a classification of our wounds into those four classes: clean, contaminated, and dirty infected. That's class 1 to 4. For class 1, there is no need for prophylactic antibiotics. For class 2, you have to give prophylactic antibiotics. And for class 3 and class 4, you have to give both prophylactic and treatment antibiotics. Both prophylactic and treatment antibiotics. All right. So, what are prophylactic antibiotics? These are broad spectrum antibiotics that are given to prevent infection. You need to prevent infection. All right. So, there are other definitions you need to be thinking about right now. What is an infection? What is colonization? What are the cardinal signs of inflammation? What are the signs of infection? You need to be able to answer these questions, right? So, still on prophylactic antibiotics, right? There are two things which are very important. First one, when do you give the prophylactic antibiotics, right? So, you give 30 to 45 minutes prior to the incision. That is, you can give it anesthetic induction. So why do we have to do it a little earlier? So this is because we want the antibiotics to reach the maximum inhibitor concentration. The second item that is very important is that prophylactic antibiotics is usually a single dose. It's one dose. But there are exceptions. If there is excessive bleeding, you may need to give another dose. And if the procedure is lasted longer than 4 hours, you need to give another. And depending on the indication, probably you have to continue, and probably your aim will interlace with the treatment, right? But those are the exceptions. I said prophylactic antibiotics, one dose. Exceptions: excessive bleeding, operation longer than 4 hours, right? So how do you choose the antibiotic, right? So there are three criteria that you use. The first one is the site of the operation, right? So it depending on which part of the body are you operating, and with that part of the body, they are expected flora. For example, if you are invading the colon, you're exposing there. Mostly they are anaerobes that you find there, right? So you have to think of metronidazole and clindamycin for the anaerobes. So there is this rule of thumb. It says clindamycin is for anaerobes above the diaphragm, and metronidazole is for anaerobes below the diaphragm. Like, it's just a rule of thumb, right? Then the second criteria, so this is based on the hospital protocol. The hospital have its protocol, like in terms of antibiotics, you use this and this and this if you do this operation, for example. And the third one is use of local guidelines. And here in Zimbabwe, we use EDLIS, which is produced every 5 years. We are updating it every 5 years, right? So I think this is the most important information you need on surgical site infection. However, if there is something you feel like I didn't mention, especially the route of administration, you just put in the comment section, and I'll um, make sure I pin that comment so that we can all learn here, right? So this comment section has to be rich. Someone watching the video, by opening the comments, should be learning. I said I want active learners. I hope you understood that. Thank you so much. I hope this video was useful to you, and if so, please make sure you subscribe, share with your friends, and like this video. Until next time.